Welcome to AHRQ's webinar on improving diagnosis and treatment of adult depression through digital healthcare. Although a few people are still logging in, we're going to go ahead and get started on time. My name is Sheena Patel, and I will be moderating today's webinar. I currently serve as a health research scientist in the Division of Digital Healthcare Research, which is part of the Center for Evidence and Practice Improvement at AHRQ. Next slide. The agenda for today's webinar should now be displayed. Please note that we are recording this webinar and that the recording and slides will be available on the AHRQ Digital Healthcare Research website in a few weeks. You will be notified by email once they are available. Next slide. We are pleased to have with us today an esteemed group of presenters. They include Dr. Neda Laiteerapong, University of Chicago, Dr. Carolyn Turvey, University of Iowa, Dr. Adrian Aguilera, University of California, Berkeley. This webinar is accredited by Affinity CE. If you're interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that the AHRQ, SD Solutions, and Affinity CE have no financial interests to disclose. Dr. Laiteerapong and Dr. Turvey also have no relevant financial interests to disclose. Dr. Aguilera has the following relevant financial interests to disclose. He is a consultant for Cindy Health, Mobile Health Consumer, and K-Health. He is also an advisory board member for BME Health. Also, please note that no commercial support was received for the development of this learning activity. Next slide. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. Please include the presenter's name or their presentation order number, first, second, or third, with your question. As a reminder, participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. Next slide. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to describe how electronic patient-reported outcomes can improve depression diagnosis and treatment, identify depression-specific digital health patient portal features that promote patient engagement, medical adherence, and reduction in depressive symptoms, understand advantages and barriers to adaptive versus static messaging interventions for depression and self-management, and evaluate the overall impact of patient-engaged digital healthcare interventions on adult depression. Next slide. And now, it is my pleasure to introduce our first presenter, Dr. Neda Laiteerapong. Dr. Laiteerapong is Associate Professor of Medicine, Medical Director of Primary Care Behavioral Health Integration, and Associate Director of Clinical Outcomes for the Center for Chronic Disease Research and Policy in the Departments of Medicine and the Department of Psychiatry and Behavioral Neuroscience at the University of Chicago. She is a health services and outcomes researcher, board certified in both internal medicine and clinical informatics, who studies translational questions at the intersection of mental health, diabetes, and individualized care. Much of her research and informatics work has focused on implementing system-level interventions in and outside of electronic health record for how increasing the provision of and access to mental health care in primary care and other settings. And now, allow me to turn the control over to Dr. Laiteerapong.
Thank you so much. I'm really excited to be here to give this webinar. So I'm going to go ahead and get started, and I hope I've got this working. Okay. I'm going to be describing some work today that was funded by AHRQ U18, and I have nothing else to disclose, as mentioned before. So my objectives today are to describe how patient-reported outcomes in a patient portal can improve depression diagnosis and treatment, then describe the implementation and evaluation of two randomized studies that we conducted, one on screening patients in patients who had no history of depression in the electronic health record, and then a monitoring trial for people who had a history of depression that were getting care, primary care. And for time course, the screening trial happened just before COVID, and then the monitoring trial actually happened during COVID in 2020. Then I'll discuss some challenges and lessons learned. So as many of you know, measurement-based care can help improve depression symptoms. So studies have shown, multiple studies have shown that regular assessment of depression symptoms using validated tools can actually optimize depression screening and treatment such that you're able to assess how people are doing and then decide if people need treatment or not, intensification of treatment, and can increase the chances of remission. So theoretically, systematic depression symptom assessment could lead potentially to more timely treatment initiation and adjustment of treatment, and then potentially greater symptom improvement and remission. Thinking about how depression is treated, this is a really great paper by Professor Pence that talks about the treatment cascade in primary care. I'm a general internist, and so this is sort of my world, and thinking about it from a public health perspective. So imagine 1,000 patients in primary care. Among those 1,000 patients, usually about 12.5% are thought to have depression. Then only about half of those patients actually are clinically recognized, so about 59 out of the 125. And the cascade continues to go down. So about half of those patients get treatment at all. Only 40% get what we considered adequate treatment. And then only 65% of the people who get adequate treatment actually achieve depression remission. So you're starting off with 125 people out of 1,000 who have depression, and you're left with only 8 patients who achieve depression remission. Now the cascade in the last step from adequate treatment to treatment remission, a lot of attention has been paid on that question of, are primary care providers providing adequate treatment? Are we just starting at the starting dose of drugs? Are we referring patients to a mental health specialist, but then the patient doesn't actually get into the mental health specialists? So that, is a combination of the 65%. And then this issue of clinically recognized depression to treatment. So are we starting treatment? And a lot of attention is paid to trying to make sure that we train our primary care physicians to feel comfortable taking care of people with depression. What I want to focus on is actually this 47% and this 40%. To actually recognize that someone is depressed, the person needs to come or be present in clinic. And so if someone's not coming to the doctor's office, it's really hard to know right now, the way the healthcare system is built, that the person has depression. And a lot of times we might start someone on something, but many times it's not the right dose. So we start someone on a drug, or we refer them to a mental health therapist, and we don't know if they're actually getting the right type of treatment or enough medications. And so this 47% and 40% I'm going to come back to a little bit later. So in primary care, what are the current options? And I'm not telling you anything that you don't know already, but I have it kind of organized in a hierarchy of how are patients with depression screened for and assessed. So a very common way is that the primary care provider notices when they're talking to a patient, the person looks kind of down. They've known the person for a long time. The person's just not looking quite like themselves. And they sort of use their clinical judgment to sort of say, oh, maybe we should talk about your mood. And then maybe at a higher level of evidence that the primary care provider just doesn't assess them for the DSM criteria for depression, but they might use a validated screener, so there's less subjectivity. So for example, a PHQ-9, a patient health questionnaire 9, or PHQ-2. First 2 items of the PHQ-9 are very commonly used, and there's a bunch of other tools that are out there that can be used as well. And of course, the validated tools are what's recommended in clinical practice, as I start off by saying that measurement-based care has been shown to be effective to identify and more effectively identify people with depression, but also quality measures from insurance companies are asking us as primary care providers and the healthcare systems to use validated screeners. Another step that a lot of clinical practices use are medical assistants. So asking medical assistants to administer the validated screener or give the person the screener to complete. So either some medical assistants are asking the questions verbally, which is not the intention necessarily of these brief screeners, but sometimes that's happening for efficiency. And then other times, medical assistants are giving patients a sheet of paper or a tablet to fill it out. And then those are sort of the 4 common ways that I think a lot of places are doing depression screening in clinical practice. And then here are some more advanced ways. So some clinics during the check-in process will give certain patients screeners, sometimes all patients that come to the practice, or sometimes just the patients who are due for screening. And then the medical assistant enters the data if it's on paper or they're using a tablet. And then probably the most advanced method that I've heard about in clinical practice is a pre-visit electronic questionnaire that is sent out to a patient via a patient portal for the patient to complete it, and then the results go to the primary care provider to review. And then a clarifying question about how questionnaires are different than validated screeners. I'm using the words interchangeably right now. The terminology questionnaire is just the terminology that the patient portal that I use. They call it a questionnaire, not a screener. So just switched over to that terminology. So going back to that framework I showed you before by Brian Pence, this is the 1,000 patients, and this is the 125 patients who have depression. And what is missing from that cascade is that our healthcare system relies on patients to come to doctor's appointments to be clinically recognized. But this cascade to be clinically recognized is a series of steps. Patients have to choose to schedule an appointment. They have to actually schedule the appointment. They have to attend the appointment. And then at the appointment, their depression has to be assessed. A lot of times we focus on, we sort of assume people come to clinic and their depression is assessed, but there's a bunch of steps that had to happen before the person comes to clinic. And a lot of literature actually supports the finding that patients with depression are more likely not to attend clinic appointments. They're more likely to no-show, cancel, and then use emergency and urgent forms of healthcare to try to get help for physical problems and sometimes mental health problems. So the trials that I designed, we're trying to look at this problem of trying to get at this problem of the 47% and the 40%, the people who don't come to clinic, and trying to see if we could improve healthcare for those people, and if that would overall improve care for people with depression. So the goals of the Pragmatic trials were to evaluate the implementation and effectiveness of population health, portal-based versus visit-based usual care for depression screening and monitoring and surveillance. And I'll provide more details in the next couple slides. So the patient criteria was quite similar. We only included adults in these studies. They had to have a visit to our primary care clinic in the past 26 months if they were between 18 and 64, in the last 14 months if they were 65 and older. That was defined at our health system level as a person that was attributable to our primary care clinic and that we would be considered responsible for their care and their preventive health care. They had to have an active patient portal account, so that way, because our main intervention was via the portal. So we wanted to see similar people. We know that there's differences among people who sign up for a patient portal and those who don't. So we required that all the patients actually have an active portal account. So the randomized arm and the control arm were similar, at least in those other characteristics. And we had to have a primary care provider in our clinic who agreed to participate. There were 2 different trials, one for patients with one with a screening trial for patients with no history of a positive screen and no history of any screening in the past 12 months. So they were due for screening at our clinic. We screen for depression once a year. So those people who hadn't been screened in the last year and had no history of depression or a positive PHQ scored at 10 or higher could be eligible for screening. The screening trial, and then the monitoring trial was for people who had a history of a depression diagnosis or a positive depression screen in the past year. Our setting, I'm at the University of Chicago. This is where we did this study. It's an urban hospital-based internal medicine and actually internal medicine pediatrics practice. And we care for about 30,000 patients per year in this practice. Before this intervention, we had already built health maintenance and best practice advisories in the electronic health record when patients were due for depression assessments. And in terms of screening, that was, as I mentioned, it was already built for people who had annual assessments. For those without a history of depression, they were due once a year to get assessed. Surveillance was a once a year PHQ-9 for people who had a history of depression, but their last score was less than 10. And monitoring was a monthly assessment for patients who had active depression symptoms. So we already have those 3 health maintenance topics and best practice advisories. And then in terms of the protocol, we already had a protocol for medical assistants to do PHQ-2s and 9s, or an adaptive mental health assessment that was built into our electronic health record for screening, and then a PHQ-9 for surveillance and monitoring during triage. And in response to the question about there's a question right now in the chat about the percent of patients who had access to the patient portal. And I would say that the University of Chicago has made a concerted effort. This was back when we started in 2018, of engaging patients and using the patient portal. And at the start of our study, 60% of our patients in primary care had an active patient portal account. So we had very high patient portal engagement. The national estimates in 2018 were about 25% of patients had active patient portal account across the country. And looking at data since COVID, we don't have data since 2021. I was just looking this past couple of days on the rate of portal usage across the country. But I think it's about 40% across the country on average have an active patient portal account. So these were pragmatic trials, and both trials were run similarly. As I explained a little bit, the usual care arm, this is what they had. So they had an alert in the EHR when the primary care providers could see that they were due for depression screening, monitoring, or surveillance. And there was a best practice advisory that was not mandatory, but you could see it when you opened up the chart, if you looked in the right place, that the person was due for an assessment. At the clinic visits, the medical assistants would administer the screening if the patient was due, and if the medical assistant didn't do it, the primary care provider could also do the screener themselves. And that was usual care. For the population health arm, they got all the same interventions as the usual care arm, but they also got the portal-based interventions. And these looked like the following. So there was an invitation via the patient portal to complete this adaptive test version of depression screening called the CADMH. And these invitations were sent to patients whether or not they had a scheduled appointment. So this was not a pre-visit assessment. This was, this patient belongs to our primary care population. We are responsible for their care. We are going to, we're wondering if they're depressed or not. They haven't had an assessment recently. We're sending you an invitation to do the assessment. The results automatically were saved into the electronic health record and were sent to the primary care provider. And if the result was completed, then the the appropriate health maintenance topics were completed. And then if they came to clinic for an appointment, and they wouldn't need to repeat the assessments. So their assessments were done. And if a patient had moderate to severe results in terms of the depression symptoms, the primary care providers were also alerted separately, then they're in basket, and also had access to clinical decision support tools for managing depression. Okay, in terms of the demographics of our clinic, we did a one-to-one randomization between the usual care arm and the population health arm, so there were no differences. So what I'm actually providing here in the 2 columns are the overall ends and their demographics for the screening trial and the monitoring trial. And you can see that the screening trial was a little bit larger, but they're both large studies. So 2,700 patients in the screening trial and almost 1,500 patients in the monitoring trial. On average, they were about 55 years old in both studies. The proportion of female participants was larger for the depression monitoring trial, which was not surprising. But otherwise, race and ethnicity distributions were the same. Where we're located on the south side of Chicago, about half of our patients are African American, 40% 45% white, and small proportions of Hispanic, Asian, and other. And so here are the results for the depression screening trial and the overall screening rate. On the left hand, on my left-hand side, the population health arm, results are there, and then on the right are the usual care results. In gray on both pie charts are the proportion of patients who were not screened for depression at all during the trial period, and the trial ended up running for 10 months. We had to truncate it. It was supposed to be 1 year, but because of COVID and the shutdown of clinic visits, we shut the trial down 2 months early in March 2020. And then you can see in the population health arm, we had 18% of patients who responded to the portal invitations to complete depression assessments, and 25% completed them during clinic. And during the usual care arm, 1/3 of patients had a depression screening during the 10-month period. So there was a statistically significant difference of 43% versus 33% in terms of having a measure of people's depression symptoms. And then here are the results for the depression monitoring trial. So same schema. So on the left, population health, on the right, usual care arms. Dark gray are no assessments during the study period. And this ran for a 12-month period. And in the reddish colors, you have the proportion of patients who had assessment during a clinic visit, and in the portal arm, it could be clinic visit and portal. So some people filled out more than one assessment for the monitoring trial. And then you can see a really large number of patients, 40% of 728 people, 40% completed a portal-based assessment of their depression symptoms. And this difference was statistically significant. And we also did a subgroup analysis looking at, there was a stop in care for a while because of COVID, and so we actually did look at after COVID, looking from July 2020 to June 2021, and we still had a higher assessment rate in the population health arm, 41% versus just 12% in the usual care arm. So screening is great, assessing people's symptoms is great, but really we're trying to get at identifying people with moderate to severe depression, people for whom we think treatments would be very important. So these are results from the screening trial in terms of the severity of people's symptoms. And in the green color, it's the population health arm, and the purple color, it's the usual care arm. And what you can see is that more people in the population health arm had higher rate, more people in the population health arm had moderate or more severe depression symptoms. So our screening trial seemed to pick up not only complete more screenings, but also people were more likely to have moderate or severe depression. And that was statistically different. And then the same results for the monitoring trial. So patients with moderate who were in the population health arm, over 70% of them had moderate or severe symptoms compared to about 50% of people who received assessments during clinic. So not only are they more severe, you also have to think about the absolute number of people. So, because more people were assessed in general in the monitoring, in the portal arm, we had a lot more assessments and a lot more that were moderate to severe. So those are our overall results, and those should be coming out hopefully in the next couple of months as the papers get out. And I thought I would end with talking about some lessons learned. So as I started off, with that description of the different ways that people can get depression assessments. Depression assessments is not 100% in primary care. And I think a major lesson learned is a combination of strategies is probably best. I'm sort of highlighting in red sort of the best best practices, I think, in terms of assessing people's depression symptoms, using a validated screener rather than clinical judgment, having the medical assistant give the patient the screener rather than reading it out loud. If you can engage the front desk staff to participate in some of these assessments, providing those, doing a pre-visit questionnaire. If you have the IT support to send out pre-visit questionnaires, I think that would be ideal to decrease the amount of workload during clinic. And then population health strategy, like I put out, and I did put a question mark there because right now, for many reasons, and a couple of them are highlighted in the next slide, it took quite a bit of work to get this population health arm off the ground. We had patient and providers, lots of feedback on our invitation letters so as to not offend or make people too worried about why we were reaching out to them. We had used adaptive test, which I didn't go into a lot of detail for the sake of time, but we used an adaptive test compared to the 2-item questionnaire because it has a much better area under the curve. It's more sensitive. But using that adaptive test required us to do a web link. So it was click out to a web link, and a lot of patients did not click through to that web link. And so it's a trade-off. Like 2 items is really quick and easy, but the adaptive test is better, might require 4 to 5 questions, but then people have to click out to it. Some patients actually came back to us and were like, I don't understand why you're contacting me after I filled out this questionnaire. Some people have very little insight into their mood and that they might have a mood disorder. And some patients were a little offended that they were answered these questions, answered them, had moderate to severe depression symptoms, and they did not think they had a problem, and they didn't know why they had to that their primary care provider or their care team was reaching out to them. So that was a very interesting problem that we had to deal with. But overall, there were very few patient concerns. We had lots of positive feedback from patients as well, and we're actually doing some qualitative work looking into that part of things. The other thing I would say, which is not on the slide, is the current quality measures, for example, ECQM quality measures, are not incentivizing population health depression assessments. At best, they're incentivizing 14 days prior to an office visit, assessing someone's symptoms. But there isn't a big incentive from quality measures to actually do this kind of work. So implications and future directions. And I'm just one of 3 talks, so you'll hear a lot more about this in the future. Portals can increase reach and frequency of depression screening, surveillance, and monitoring. A population health approach using the portal, in our case, increased depression monitoring and surveillance, though it was just at one site and with a certain particular patient population and certain clinicians, and as yet, likely problems with generalizability. However, it's pretty clear that a visit-based strategy probably misses many people, and in some cases, the most who might be in need of mental health care. And in terms of future directions, combining this type of approach with integrated behavioral health models like the collaborative care model, or someone who can systematically review results so as not to put the burden back on primary care providers could be important. And then other population health strategies are likely needed. There were problems with, people would fill out questionnaires up to 9 months after we initially sent them. So there are all sorts of little problems like that. And there are no differences in portal engagement and some stuff in our study and then other studies that's well known. So how we not exacerbate disparities, I think, is also quite important. I want to thank a very large team of people who helped me with this project. And this is my contact information.
Thank you, Dr. Laiteerapong. As a reminder, we will be taking questions after all presentations, so please submit any questions you have using the Q&A panel. Let's move on to our second webinar presentation, which is being led by Dr. Carolyn Turvey. Dr. Turvey is the co-director of the Veterans Rural Health Resource Center in Iowa City. Her center promotes research, innovation, development, and testing, and quality improvement projects whose overarching aim is to improve access to high-quality care for rural veterans. Dr. Turvey is also a professor of psychiatry at the Carver College of Medicine at the University of Iowa. Her research and quality improvement work focuses on the use of telemedicine and e-health to promote independence and mental health in people with poor access to medical care. Her recent focus has been on consumer health informatics, patient portals, and patient engagement through measurement-based care. She is currently implementing a measurement-based care protocol to improve coordination of care between VHA and community providers. And now I would like to turn the control over to Dr. Turvey.
Thank you. So today, consistent with the other presenters, I'm going to talk about patient-facing health informatics with a special use case of mental health and in particular depression. Depression is one of the most debilitating illnesses and is certainly quite common. So patient portals can be a really essential tool, but I think the special use case of patient portals in the context of mental health care generates some anxiety and concerns amongst providers, and patients maybe are less aware of the role of patient portals and how they can use them in their care. So this is really a developmental grant. This is a small but very appreciated proposal to look at both patient and providers' experience of patient portals in the context of mental health care, and then to start to develop different use cases for how uh, clinical teams can work with patient portals to enhance the management of depression, both provider management of depression and patient self-management of depression. So this is a user-centered design model where we'll go in and talk with the users about what their experience has been so far and what they would like to see in the future. My co-investigators on this project were Dawn Klein, Lindsay Furmeister, and Emily Chasko. The aims of the study was to talk with stakeholders about portal features that they're using, and what their experience has been and what they would like to see in patient portals in the future to help enhance their care. I would integrate these qualitative results to develop an intervention to increase patient engagement and provider engagement with patient portals, um, and then test this in just a small pilot to see if it helps with adoption of portals and also with management of depression care. So I think everybody on this call they're familiar with portals, people use them. I think that, and we'll talk a little bit about the adoption, the aim here was that it was my experience that people used maybe one or two features of their patient portals. They would maybe go in, check on their lab results, or go in and check on an appointment, but it really wasn't seen as a self-management tool. And in particular, providers had at times ambivalent feelings about portals, which they kind of saw them as things that maybe just increase their workload, instead of something that if they used them in the proper manner might really enhance their care and might actually decrease some workload. The example that I give when people talk about what features in their portals that they use, if you just go in to check your lab results, and maybe message a provider, that would be the equivalent of having an iPhone and only using it as a phone, when there really are a lot of other ways that portals can be used, that we're going to talk about and that have already been talked about by the prior speaker. Patient portals are secure online websites where patients can access their health information. This study focused specifically on a patient portal that was tethered to the electronic health record. There are portals that are tethered possibly to pharmacies or to insurers, but what I'm really talking about are the patient portals that you might see tethered to Epic, MyChart, Allscripts, Cerner, that's really a portal that is embedded within a larger, more standard electronic health record. We're talking about portals that include secure messaging as part of the features and includes access to visit notes. I think we're very indebted to the foresight of the Office of the National Coordinator in really putting patients first and making adoption and promotion of patient portals part of their um, uh, meaningful use criteria. I am at the University of Iowa, and I would say that our front office was maybe interested in patient portals, but that it was really required as part of meaningful use criteria provided the first impetus. After the portals were implemented, they got a lot of good feedback from patients directly, more mixed feedback from providers, but definitely from patients. And so I think that really started the ball rolling. Here, nonetheless, though, we have some data. This is data from the Office of the National Coordinator, and the blue line is the proportion of patients who completed a survey who said that they were offered a patient portal, and then of those, the proportion of patients that signed up. So we still have a way to go, even with adoption of patient portals, and then once it's adopted, my work is focusing on making sure that people do full, meaningful use of the portal. Related to that, in the same survey, they asked patients, well, what did you do with your portal? And the predominant use was viewing clinical notes and secure messaging. And I'm sure people are familiar with the Open Notes program that focuses very much on trying to promote the idea of patients actually going in and reading their clinical notes. There has been some concern about mental health in patient portals and providing access to mental health notes, that somehow patients going in and seeing what their providers say about them after a psychiatric visit or a psychotherapy visit would somehow be distressing or cause some issues with the alliance. But most mental health providers, actually, I won't say most mental health providers, but most proponents of patient portals really don't like there to be divides between divisions in mental health. We really don't want to say, oh, it's okay. It's okay for you to get access your notes to your primary care provider, but no, we're going to say there's something different or special about mental health, and we don't want to provide access to those notes. And once again, the Office of the National Coordinator had the foresight to say, no, for meaningful use, we really want you to provide access to all notes. And as a psychotherapist, I think that people really need to be thinking about when they write their notes that patients are going to be able to see this, but there can be opportunities in that, and it doesn't necessarily have to be a cause for concern. Another thing, just I don't like anything where there's a silo for mental health. It almost always doesn't work out well for patients seeking care in mental health or for the providers. And I wonder about other aspects of medicine. Certainly people who are treating patients within urology or OB-GYN, they're having some tough conversations too, and that's getting documented in the medical record. So I really think, once again, this idea that mental health is different than other aspects of health is really, uh, once again, stigmatizing mental health. So the 21st Century Cures Act, which I believe went live in April of last year, but it might have been 2 years ago, that said, no, you need to provide access to mental health visit notes as well as all of the rest of the medical notes. But a lot of the interviews that I conducted as part of this study occurred before that was implemented. So as part of the initial development, I provided an online survey to providers nationwide who are participating in the National Network of Depression Centers, as well as providers who work within the VA. And we asked them about their experience with patient portals and patients' access to their notes. The survey responses, these were the top responses of what were the implications of patients having access to their notes. 72% said patients requested a change in their note. 69 reported that it led to patients asking more questions. And 69% said it led to patients experiencing distress after reading the note. Having a patient, they didn't say it was all of their patients, but these were some of the experiences that they had. And they did have some positive experiences that they endorsed, but I have to say the provider experiences were somewhat mixed. In contrast, when we talk to patients about accessing their notes, they were much more positive. So here again, this was before the Patient CARES Acts. Only 22% of our 168 patients had a patient portal where they could access their mental health notes. Hopefully that number would be much higher now. But of those, 86% said they have a better understanding of what happened during their appointment. And that is such a huge impact of being able to read your notes. I mean, I think that people understand this, but may overlook the fact that these visits often occur very quickly. A lot of complicated things could be occurring during those visits. So patients are seeing going back into the chart as a way of being able to sit and process a little bit better some of the hurried discussions they may have been having during the medical visit. 84% report trusting their provider more. And when we fleshed out this result by asking them to describe that in more depth, they said, you know, I was always wondering what he was thinking about me. This isn't psychotherapy notes. I always wondered what he was holding back. And then they go and read the note and realize, oh, actually, he really is just treating me for depression. There's not a mystery there. This is what you see is what you get. And so reading the note helped many of the patients that we spoke with trust their provider more. And then 81% endorsed feeling comforted or relieved after reading their health information. Providers, I think, are getting a more sophisticated understanding of how to work with portals. This first provider said, there are several things I'm not comfortable managing via the portal, but I do prefer getting initially notified about a problem via the portal, and then I follow up via the phone. And I really think that that's an important thing to consider, that there are multiple ways that providers can use the phone or portals or in-person visits, and they can try to coach patients on the most efficient ways to use those so that they can help interact with the patients and meet their needs, but also not have too much overwhelming workload. One provider said, I have very rare instances where a patient said something inappropriate. I found it helpful to have a conversation about the portal, stating that it is not for emergencies. And so what I'm promoting in my intervention is to not have a black or white sort of experience of portals, but to think more and more about how to use it as a collaboration tool. Patients said when coming to medical records, having immediate access to them helped me in so many ways on so many occasions. I look forward to the future on how they will expand. I currently use my chart, so every provider in my area that I go to utilizes it, and it's just phenomenal. By the way, these aren't like cherry picked. I mean, it was really quite overwhelming. The providers had mixed feelings, but the patients were overwhelmingly positive. Being able to connect with my provider through the portal and skip a lot of hurdles is really a different way of life. It also helps that my providers are fantastic people who are aware that sometimes just one simple question answered via message can make a world of difference. In my experience, everything depends on the provider's willingness to use the portal as a valuable mode of communication. So in our intervention, which was just a small pilot RCT, we developed a way of training patients to use all of the features within the patient portal and to talk about the concept of using the patient portal as a collaboration and self-management tool for depression and depression treatment. We also did a training session with providers where we addressed some of their concerns about workflow and communication with patients about patient portals. But we also shared with them the patient's overwhelming positive experience of portals to show them that this was something that patients could be using as a something that providers could be using as a tool. In addition, we started to explore the idea of measurement-based care where through the portal we conducted monthly assessment of depression measures, which we built back into the EPIC system so that patients can go in and look at their depression scores over time. And then we checked in with them and asked them if they were doing that and how they experienced looking at their trends over time of the depression measures. We also added measures of functioning, which we were not able to build into EPIC at that time. But this is an area of innovation that I want to go forward with in measurement-based care to combine symptom-based measures with measures of either quality of life or functioning, because I believe that functioning is the final common denominator in really all medical treatment. It's kind of where you can tell, and many of the patients that we have many, many comorbidities. So to just treat all of these individual symptoms separately and not look at the big picture, I think is a disservice in the context of measurement-based care. In the comparison condition, I simply trained patients on how to use their patient portal and showed them the feature, but I really didn't try to convey as much this concept of it being a collaboration tool with the providers. And then we did assessments of depression and functioning at baseline, 3 and 6 month follow-up. Very small sample size pilot study. This was an example of the feedback they would get over time. The blue line was their depressive symptoms and the black line was their functional symptoms. This patient happened to have them go right in lockstep, but that wasn't always the case. And then there was often a talk about, well, how is your depression going? How is your functioning going? And how do they relate? I have to say the preliminary results weren't overwhelming. Initially, Connect Care did show a significant decline. That's the blue line here on the 9-item patient health questionnaire, so that they went down about 5 points, which is considered a clinically significant decline on the depression measure. And that was less so for the people in the comparison condition, but that evened out by 6-month follow-up. Similarly, when we looked at functioning, it does look like the people in the Connect Care initially in the first 3 months had a nice decline. That a decline is good. It means they have less impairment. So we wanted to see that decline, but it looked like at 6 months, the two groups started to approach each other again. I think that there's more that we can do to make this a more impactful intervention. So I think we have a signal of some impact, but I think that the lesson learned, the main lesson learned is that that intervention needs to have a little bit more meat to it. We did talk again to the patients and their feedback was again very positive. Just by answering the questionnaires, I found areas I really needed to work on. And here at the bottom, the questionnaires help me think about my depression, and instead of one looming and overwhelming cloud, breaking it into individual characteristics is helpful. So I'm very interested in this concept of using measurement-based care not only to kind of measure patient-reported outcomes, but to help increase patient understanding of what mental illness and depression is, and to try to demystify the treatment of mental illness so that it doesn't feel so vague and amorphous and insurmountable, which I am seeing in some of my other work in measurement-based care. This is an example of the graph that we built inside of MyChart, and this is now a standard feature for all patients getting care at the University of Iowa. If they go in, any assessment that they take of depression, they can go in and look at their trends over time and use that as an example to inform their understanding of whether or not their treatments are working. So lessons learned, patients have positive experience around patient portals, and engaging patients with their portals and the providers may slightly impact depression and functional outcomes. The providers were more positive about secure messaging and really needed a bit more of kind of coaching about the idea of using a patient portal as a way to collaborate better with patients, which I believe they were receptive to once some of their concerns about workload were addressed. That's my contact information, and I'm ready for the next speaker.
Thank you, Dr. Turvey. Please feel free to submit any questions you have using the Q&A panel at this time. Moving on to our final presentation of the webinar, which is being led by Dr. Adrian Aguilera. Dr. Aguilera is an associate professor in the School of Social Welfare at UC Berkeley in the Department of Psychiatry and Behavioral Sciences at UC San Francisco. He is trained as a clinical psychologist and is an expert in cognitive and behavioral approaches to treat depression and anxiety. Dr. Aguilera's research is focused on developing and testing technology-based interventions to address health disparities in low-income and vulnerable populations. His work has focused on utilizing mobile phone technologies to disseminate mental health interventions and leveraging digital health for equity. And now I would like to turn the control over to Dr. Aguilera.
Great, thank you so much for that introduction. It's great to be a part of this panel. Today I'm going to talk a little bit about a project that that we've been working on for the past few years, and we're not quite done with it, so I won't be able to present full data. But let you know what we've learned to this point and where we plan to go. Before going forward, I want to acknowledge this project. The co-PI for this project is Courtney Lyles, my colleague at UC San Francisco, who has been working with me and is in particular more of an expert on the diabetes side, and I'm on the depression side. So it kind of makes sense for me to be here. So the focus of diabetes and depression started to some extent because I was focused on depression and noticed that in primary care, so many of our patients, particularly Latinx Spanish speakers, were coming in with issues of diabetes. And we noticed that comorbid diabetes and depression essentially worsen each other. They make each other's prognosis worse, and so we thought of how we might be able to address both with some overlapping factors that impact both. One of the key factors that we recognize that's important in both diabetes and depression is physical activity. Specifically in depression, we know that physical activity is thought of under the behavioral activation framework. So the more pleasant activities, the more activity that folks are involved with, the more opportunity they are to experience positive reinforcing events, social contact, reducing isolation, etc. And we know that it also improves diabetes, so that was a good target that we thought could address both, and also other physical health problems, but these are our areas of focus for now. And there are quite a few mobile health apps focused on activity. Broadly speaking, there are some positive effects of mobile health apps. A meta-analysis of 9 RCTs found that apps have a moderately positive effect on increasing physical activity and also on increasing step changes, step count. However, our particular focus is thinking about health equity and health disparities when we're working on digital health interventions, because digital health interventions are often not designed for populations with the most need. So our focus is people with low-income backgrounds, with low levels of health literacy, and from ethnic minority backgrounds. All of these factors also contribute to higher prevalence and worse outcomes in both of these targets. Broadly speaking, one of the challenges, as I mentioned, is who is being designed for. And here you see some popular wearable devices that focus on physical activity tend to focus on people who are already healthy. So let's say increasing somebody's physical activity from 7,000 steps to 8,000 steps, or even 10,000 to 11,000. And so that's a marginal difference when you compare that to, let's say, increasing somebody's steps from 3,000 to 4,000, right? That would be a 25% or 33% increase in step count compared to, let's say, 10%. So really focusing on need. Another challenge is that many digital health apps tend to be focused on being available in English. So that makes a whole swath of the population not really able to access these interventions. One challenge that we face is that we know in digital health that personalization is really important. And while this is increasingly a point of emphasis, most apps are still not quite personalized to users. And we definitely also need group level and cultural adaptation. But even these types of personalizations don't account for personal differences. So what we wanted to do is utilize a reinforcement learning approach, which is a type of machine learning that I'll explain in a little bit, that allows for us to predict the most effective content that can be most effective in motivating for physical activity. So the goal is to leverage text messaging to provide personalized motivation for physical activity. So the Diamante project, as I mentioned, focuses on depression and diabetes, focusing on physical activity with these core elements of personalization, integration into care, and a focus on vulnerable populations. The outcomes that we're interested in primarily are physical activity. So we're trying to see if we can help folks become more physically active. And also we're tracking mood on a regular basis and want to see if there's some positive influences on PHQ-9 and HbA1c as well. So this is one way of kind of thinking about how it works. We send messages to participants and then we receive step counts from their phones. And those step counts then influence the types of messages that we send. This is what the app looks like. So it's a basic step tracker over time. And then we send text messages. And so these two are linked. And in some sense, you can think about them talking to each other. So what the intervention does is it passively senses steps via the app and then personalizes the messaging using a reinforcement learning algorithm, which the goal is to target specific motivators. Okay? And so what are the motivators? So the motivators that we think about are messages related to capability, opportunity, and motivation. So we use the COM-B framework, which is an implementation science framework, to think about how to target our intervention. So opportunity might be something like doing more physical activity can help reduce feelings of fatigue and improve your mood. Capability could be something related to when somebody might be able to engage in physical activity. And then motivation often is related a bit more towards self-efficacy, kind of self-confidence is what we found. And I'll talk a little bit more about how we generated the content. But this is the general framework that we're using. The idea being that certain categories may be more influential in increasing physical activity. So just briefly, when I talk about reinforcement learning, it's a branch of machine learning. And you may or may not have heard of these terms. So supervised learning kind of uses pre-existing data. But reinforcement learning, what it does is it's just using data that's coming in. And so it refers to software agents, in this case, an algorithm, acting to maximize the cumulative reward. So taking an action, which in our case is sending a message, in order to get the highest number of steps. So it's taking all the data that it's learned from and then using that to predict which type of message at which time is going to result in the highest number of messages, in the highest number of steps. Sorry. So here's some terms that are helpful to understand this. So action variables, so this is what the algorithm is doing. Contextual variables, it's what's going on, kind of information about the participant. Reward is the outcome, the step counts. And then the model is how we predict what the potential reward might be as a function of the action and the contextual variables. So this is another way to think about it. So we get data from, we set a goal for participants. So the lowest number is 4,000, or people can set more. We use this in part based on somebody's average physical activity in the past week, and kind of use that as a way to set a goal going forward. So participants come in with some motivation to increase physical activity. So then the messaging gets optimized on a daily basis. So one thing that first we provide feedback around how many steps somebody took, whether they met their goal, etc., framed in different ways. Provide messages around motivation on getting folks to increase physical activity. And then also time of day. So the time of day is another factor in terms of whether perhaps sending them in the morning versus in the afternoon has a different impact on increased steps. All taken into account contextual variables such as gender, age, symptoms, even things like weather, for example. So once all these factors are put into the equation, the algorithm then chooses a message and predicts which one might result in more steps. And it doesn't always pick the best one. So sometimes it purposely fails. And sometimes there's combinations of messages that may be better in the long run. So maybe you send a message that is not going to be that motivating, but following the next day, it has a bigger impact. So we're doing this with, the focus has been with patients at the General Hospital in San Francisco, a public hospital in San Francisco for English and Spanish speakers, as I mentioned, with diabetes diagnosis and depression symptoms. We ended up having to expand this due to COVID and the pandemic, and I'll talk a little bit about that. And the patients either receive the reinforcement learning messages, random messages, or just the app with a reminder to track steps. So those are the three conditions. This is a design, this is some older data, but it gives you a sense of how we're allocating things. So folks are doing the randomized learning, meaning they're just getting messages at random, versus the algorithm and then the control. So this will allow us to look at a couple of things. One is, what's the intervention like compared to a control condition of just tracking steps? And then in addition, what is the added benefit of personalization, if any? So one of the main challenges that we had, as a lot of us have faced, is the pandemic, and the timing for us in particular is that we were 1 month into launching the intervention and recruiting when the pandemic kind of hit, and we weren't able to see people in person. So it really caused us some challenges, which we tried to turn into learnings and ways to improve recruitment and connection with, particularly with folks who have lower levels of digital literacy. So we weren't able to meet people in person, challenges with DocuSign, providing consent, downloading the app without support, things like that. So some of the things that we did is we developed YouTube videos on how to access Zoom, how to download the app, provided step-by-step instructions on how to access email and DocuSign, set links for downloading these like Zoom and the app. So trying to make things as straightforward and simple as possible. Other issues, we really have to provide support, kind of technical support. And then lastly, being open to having family members help participants get on board with the sessions. So as of a couple months ago, this is our what our sample looks like. And one of the things you'll notice is the online column. In order to supplement our recruitment, we just started recruiting online during the pandemic using first a combination of Facebook and Craigslist, but then moved and found that Craigslist was a better method of recruitment for our study. And so some of the key differences you'll see is that the sample at the hospital has many more Spanish speakers, and also has generally lower levels of education than the online sample. So I think once the data is done, we're actually done recruiting in about 2 weeks, and then folks will be in the intervention through December. We'll be able to, I think, look at some of the difference between a sample that's clinic-based versus one that's more community-based. One of the things that is really important to us is the issue of digital literacy. So here's an overview of access. So as you can see in our public hospital sample, there's fewer people that have Wi-Fi at home, and a bit more difficulty in using smartphones, and in particularly difficulty in installing apps. So these are challenges to digital health, but they're challenges that we believe we have to face head on and find ways to make some of this work, given the fact that digital health and applications are being disseminated so broadly. So some of the decisions that we made, one important part of the intervention was in the first phase was paying a lot of attention to designing the intervention, to working with potential participants and with the community. And so some of the things that we did were increased attention to self-efficacy. People wanted motivational messages, not just information. Others wanted more kind of education to talk about why walking is important. And then also the opportunity cues, so the how can I do it, right? So things such as leaving your shoes next to your bed so you can walk in the morning, things like that. Making the messages available at lower reading levels, etc. Other things that people mentioned were addressing social isolation, and particularly since we have a lot of Latinx patients, emphasizing family and social connections with regards to the influence that has in engaging in positive health behaviors. So far, some of the feedback that we found, as I mentioned, unfortunately, we don't have the outcomes data just yet. We hope to have that by the end of the year, the beginning of next year. But so far, patients have told us that they feel accomplished and proud of themselves when they engage. So they do have to have some level of motivation. And I think that helps to keep them on board. We talk about it coming from the clinic, from their healthcare provider, that they're identified by their healthcare provider as somebody who might benefit, and those things help to keep people engaged. And seeing the data helps them feel like they're reaching a goal, making progress. There's also a sense that somebody's checking in on them. This was especially the case during COVID, and they were able to, check in on their mental health during a difficult time. And I think having some connection with our research team who spends time onboarding folks, that's something where people are developing connections. And we know that through past research that connections are really important towards engagement in digital health. Most folks mentioned once they were onboarded that they felt the program was easy to use. And what you notice is that 2/3 of people chose to extend the messages after the 6 months. So we asked them if they wanted to keep getting messages, and most people wanted to keep getting messages for an additional 10 weeks. So there's some longevity to this type of program, which is often a criticism of these types of programs in terms of how long can we sustain this. But at least we've seen here that folks are pretty engaged for beyond even the time that they have to be in the intervention. So some of the takeaways in our project are blending co-design with traditional evaluation, paying attention to equity. And as I mentioned, we'll have more on the effectiveness in the coming months. Oops. So some of the important points I think to summarize from the talk are that digital health co-design really can improve engagement and relevance of a platform, particularly amongst folks for whom are not typically the targets of these types of interventions. This reinforcement learning approach is a novel approach, and I think the information that we're going to get from this is going to be really valuable in informing future interventions. The pandemic obviously presented multiple challenges, particularly in safety net settings. I think in many settings, people were able to access care and research studies remotely, but that's not necessarily the case in safety net settings. Online recruitment yields participants, but it's a different audience. So it's important to recognize that. And I think we'll be able to report on that as well. Lastly, digital recruitment requires in-person support. So, digital health is not going to replace the human in the loop. What we, have found is that the idea is for both to strengthen each other. And then we're going to look at how COVID impacted both not only physical activity, but also depressive symptoms during this time. So we're going to be able to have some kind of real-time data during that critical period. Thank you very much to our amazing team that's helped us carry out this project and do it flexibly.
Thank you, Dr. Aguilera, and thank you again to all of our presenters for their very informative presentations. As a reminder, please submit any questions you have for any of our presenters using the Q&A panel. This concludes the content portion of the webinar. Now we have a few minutes left for questions. You can type them into the Q&A section of the WebEx portal. And although we may not be able to get to them all today, we will provide responses to all questions in writing. You will receive an email once these responses are available. So we will start off with a question for Dr. Laiteerapong. This question reads, what was the attitude of primary care physicians to this intervention?
Thank you for this question. We did ask them, and we had a series of surveys, and I work in this clinic, so people would just come up to me and tell me their attitudes. Primary care doctors are not shy. And I would say that the attitudes evolved over time. So we overall, like in my clinic, people are very enthusiastic about depression screening. They think it's very important to do, but the additional burden, there was concerns in about, I think 40% in the first year when we did the depression screening trial about the additional burden of the assessments. And that was very early. So I do the questionnaires in July, and we launched this right around then. The year after, the year after the screening trial, there was concerns about 40% of people that the burden was too much, that they didn't like it. And then the year after with the monitoring trial, which happened during COVID, so you imagine physicians were very busy with COVID and higher rates of burnout. 60% of physicians said they were no longer concerned. So it sort of flipped. So I was getting more engagement from the providers. They saw the value in it. They had a lot of anecdotal cases of individual patients that they were like, oh, I didn't know they were suffering, and they were suffering at home, and this led to me thinking about them when I'd forgotten about them. So I would say, I don't know if those would be the same results we would get now that the MyChart use really, there's lots of studies that show that the use of MyChart has just taken off, and patient portals has taken off, lots and lots of after-hours messages, and not, no clear compensation for all that extra consultation time. And so I'm not sure if I would get the same results now, but at the time, that's what we found.
Thank you, Dr. Laiteerapong. The next question we have is for Dr. Turvey. In what ways can clinicians work with patient portals to enhance their treatment alliance with patients?
I think that a lot of the ways that I talked about about having discussions with patients about what are the appropriate uses of secure messaging and how they want to use secure messaging. As far as the access to the notes, I think one of the most important things, and clinicians that I spoke with were already doing this, but we made it one of our recommendations, is to really make their notes strengths-based. So to talk about what you were working on and what the problems were that you were working on, but then really make sure to also document what you see as the patient's strengths are in addressing those problems, as well as what they're struggling with. They are after all in treatment. But I think very much having a strengths-based approach in your note writing is going to help patients to not feel kind of disempowered as far as their care, and then hopefully they'll align more with you in working towards getting better.
Thank you, Dr. Turvey. The next question we have is for Dr. Aguilera. Why didn't you use a wearable device to more accurately track steps?
Thanks for that question. We did consider using wearable devices because they do provide a more accurate assessment, but we wanted to make our findings as generalizable as possible. And we know that folks do wear wearable devices, but they often only wear them for a certain amount of time and then stop wearing them, and they're not as accessible to everyone. So we chose the approach of taking advantage of what people already do. We know that cell phones and smartphones in particular are quite widely used compared to wearable devices. So it's a trade-off that we made. And generally, we err on the side of generalizability and applicability to make sure that these things can actually be implemented in the real world.
Thank you, Dr. Aguilera. Next question we have is for Dr. Laiteerapong. What changes to the health system are needed to incorporate this type of system into clinical practice?
That's a great question. Thank you. I think the major driver would be a change in quality measures and sort of how our health systems are being judged in terms of quality of depression care. I'm very excited that depression screening and follow-up is becoming one of the primary quality measures that most insurers or all insurers are going to sort of assess the quality of care for, but that is screening and follow-up. So that's incident depression. That is new cases of depression. For all of our patients who have active depression, who we're inadequately treating them, or they're not getting engaged in care, or whatever the case may be, that depression remission measure, which that's not the focus. It's screening for new incident cases. And I think that's very important. But that's also all tethered to a clinic visit. So right now you have to have a clinic visit for you to get into the denominator, and then see if you can get, and then the health system's job is to try to also get the screening done to get you in the numerator. So I do think that the movement towards like accountable care organizations and more population-based health, the desire to move towards accountable care organizations and other similar structures are important, because we do net patients with people who have depression use the healthcare system in other ways and can increase costs. So as healthcare systems are more savvy and thoughtful about how they engage patients, this, there's lots of evidence that addressing inadequately treated depression is a huge driver of all sorts of different types of expensive healthcare utilization, lots of patient portal messages, lots of other healthcare needs. So I'm hoping that there are lots of different types of drivers that will change the healthcare system in the future, but I do think quality measures is a big part of it, and hopefully we'll see changes in the quality measures in the future, moving closer towards population health.
Thank you for that answer. The next question we have is for Dr. Turvey. What are some innovative uses of secure messaging in depression care, and how can organizations manage clinician workload burden?
I think some innovative uses of secure messaging could be a little bit of what Dr. Laiteerapong was talking about, was not always having it tied to visits, but to have it be for between visit check-ins, or assessments that might help better time when those visits occur. There could be a time, and this does occur, where people have 6 months follow-up for depression, and they have a real bad or low depression in the middle of that time, where they could possibly prevent things like hospitalization or further deterioration if they had some assessments or some sort of check-in that occurs between visits. And I know that you might need different levels of professionals to look at those assessments. I know that this gets a lot of providers very anxious about thinking about additional work, but I think if we get creative about treatment models, that might help with the secure messaging. I also think providers can send out information via secure messaging that could be helpful to patients, and even introduce them to some of the more popular mobile applications related to distress tolerance and mindfulness. In true to form, forgot the second half of your question. Oh, how to reduce workload. I think the most important thing about reducing workload is for providers to talk in the first visit with patients about patient portals and to set clear expectations. And I feel that 99 or 97% of patients will understand that and grasp that. A little bit of an unfortunate way that patient portals rolled out was that it was kind of this top-down process, and there were times when patients were able to access provider notes, and providers didn't know that. And I think that was not the most optimal way of doing it. But I think that having providers talk with patients in the first session and manage expectations around turnaround time, expectations about what's the appropriate use. I think both patients and providers will realize efficiencies if there is a set of ground rules that providers discuss in the first visit with the patient.
Thank you, Dr. Turvey. The next question we have is for Dr. Aguilera. What factors are related to engagement with the messaging program?
Thanks for that question, Sheena. So as I alluded to a bit, one of the most important factors is having a sense of connection with some sort of provider, somebody on the other side. What we want to avoid when doing these types of digital health interventions is things that are all one way, and there's no sense of what the purpose is in the back on the flip side, kind of where our data goes and things like that. So it'll be interesting once we find the data, now that we even have the online sample. But I think that folks from the clinic are going to probably engage more because they have a sense that the clinic is involved. And we were also sending um, summaries of the data to providers so that they can see what physical activity and PHQ-9 was in the past few months. So the key is to connect the data, the intervention to ongoing care.
Thank you, Dr. Aguilera. And we have one more question for Dr. Turvey. How can the electronic capture of patient-reported outcomes enhance alliance and treatment of patients with chronic serious mental illness?
Well, we've been doing a lot of work on talking with patients in long-term measurement-based care. One of the most important things, and this was a study done by Kragalow et al., where he looked at the effectiveness of measurement-based care, and he did a meta-analysis of multiple studies, and he found that for it to really be effective, you have to do the assessment, and then both the patient and the provider need to receive a copy of the assessment. And there needs to be a discussion between the patient and the provider about what occurred in the assessment, what they see. Is the patient improving or not improving? And that sounds straightforward, but whenever I talk with audiences, I ask people to raise their hand. How often have they completed an electronic assessment and then they never hear about it again? They just go into a clinic, they complete the assessments. You don't know if your provider has seen it. You don't know if, somebody, an insurance company has seen it. You don't hear about it. And that has been shown to not be all that impactful. So I think that the first thing is to make sure that both the patient and the provider can see the assessment and then that it's actually discussed. And that's part of why I worked with our IT to get it within our Epic that the patients can go into their portal and see their traces over time, their trajectories over time. The other way, I do think that when patients see their trajectory of scores over time, there's one score, but when they see the trajectory over time, and it helps their memory, but it also helps them to get a better sense of what is meant by the term depression, which seems like it might be that straightforward, but I think that what I'm hearing a lot from patients in the qualitative work is that they're getting a more concrete idea of what the depression is, and that it makes them feel more empowered in addressing the depression. One last thing real quick. I recently had a patient say, I could bring up the quote, he said, I trust my provider more now because, when he says I'm getting better, I can actually see it on the graph. I still feel kind of low. I'm not feeling that great. But I know that I was the one who completed those assessments, and a year ago I was worse off than I am now. So now I can trust that my provider is actually working to try to help me better. So it's those types of things that I think will little by little build the alliance.
Thank you, Dr. Turvey. And I see in the Q&A panel, the presenters are responding to some of the questions via chat. So can we go to the next slide, please? Thank you. We have reached the end of our time for this webinar. Thank you for attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. You will select today's webinar, which will be indicated by date and title to claim your credits. You will have 14 days to claim your CE. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete this survey to share your feedback with us. Thank you, everyone, and have a nice day.